Good morning, everyone. Today, my topic is injury of the chest wall, pleura, and lungs. My name is Chong Zhang from the Department of Thoracic Surgery, the first affiliate hospital, Zhejiang University. This class, we should always know the outlines. It included the introduction to thoracic trauma, thoracic anatomy, classification, specific chest injuries. The first part is the introduction of the thoracic trauma. We know that the thoracic trauma is responsible for more than 20% of traumatic deaths. It is account for about 16,000 deaths per year in the United States. Most thoracic injuries just included 9% of the blunt trauma, from 70% to 85% of the penetrating trauma can be managed without surgery. This is the features. We know that the number of traumas by gender. We know this line is indicates the man. This line is indicated the woman. So we know that the man is more. The numbers of traumas of men is more than of women. And this figures is always the number of the traumas by the mechanism of the injury. That we know. The first is the MRMC. The second is fall. The third is stroke. Then we learn before we learn about the injuries, we should know about the anatomy of the chest cage. And we know that the chest cage always included. This is a sternum. This is a rib, 12 ribs. This is a spine. So the three part is encaged a cavity. Then we know. We always have 12 pairs of C-shaped ribs. This is the first from 1 to 7 is always called true ribs. 1, 2, 3, 4, 5, 6, 7, and this has the cartilages to connect with the sternum. This is the angle of the Lewis. Always connect with the second rib. The second part of the ribs from 8 to 10 join the sternum with the combined cartilage at the 7th rib. They always know this cartilage to connect with the 7th cartilage. The 12th or the 11th or the 12th is we also call the floating rib. This has no cartilage to connect with the sternum to the other ribs. This is sternum. The sternum we always call the manual brain. Then the body. Then this is always called exfield process. Everyone has the exfield process. After the skeleton of the anatomy, we always know some others, just like muscles. We always has a rib. Between the ribs has the intercostal space. They always has the muscles. Others has the artery, vein, nerve on inferior margin of each rib. Each rib has three parts, arteries, veins, and nerves. This is called thoracic inlet. This is called thoracic outlet. This is spinal. This is sternum. This is rib. Others are the muscles. Muscles we always between the ribs as external interstitial muscles. The other part is internal intercostal muscles. So all the muscles are interactive. So it is and helped us to inhalation or exhalation. So if we inhale, so the scale muscles, sternocleidomastoid muscle will always elevate. After we exhalation, so all the muscles will descending. In the cavity, we always have some most important organs. Mostly common is the lung. This is the right lung. This is the left lung. Between the lung is the mediastinum. And the right lung is divided into 3 lobes. This is upper lobes. This is middle lobes. This is the lower lobes. The left part is divided into 2 parts. This is the upper lobe. This is lower lobe. And among the lungs, we always have the bronchi. This is trachea. This is bronchus. They are divided into 2 more small bronchus. This is anatomy of the bronchus. So the bronchus has 3 parts. 3 parts in the right side. This is upper bronchus. This is middle bronchus. This is the lower bronchus. On the other side of the left this is the upper bronchus. This is lower lobe bronchus. So we know this anatomy is helped to learn about the injury. After we learn about the anatomy, so we should know the classification of the thoracic trauma. Always, it's very easy to divide into 2 categories. One is by organs. It includes simple, closed pneumothorax, open pneumothorax, touching pneumothorax. Others include the frail chest, cardiac tamponade, traumatic aortic rupture, traumatic asphyxia, diaphragmatic rupture. If we divide by force, we always divide into blunt trauma. It is always caused by the forceful blow to the chest. The second is penetrating injury. Is an object penetrates the chest wall. The third part is a compression injury. The chest cavity is compressed by rapidly, usually during automobile accident. The general signs is very common and symptom very common. So just like the pale, the cool, climbing skin, which is always the cold skin. The cyanosis, though the patient has no oxygen, so the patient's lips will get blue. This dyspnea, rapid breathing is always more than 20 breaths per minute, tracheal deviation, pain during breathing, distended neck veins. All these symptoms, general signs, always should to observed in the patients. So everybody should know about the general signs. Then we talk about some specific chest injuries. The most common is the rib fracture. When an emergency doctor meet a patient, the first part of the most important point of the treat management of the patient should we know about the rib fracture. The incidence of the rib fracture is always infrequent until adult life, so it is always more important in the elderly. Significant force required most elderly patients. But the mortality and mobility is always can lead to serious consequence, from minor to patients to the death of the patients. Older people's ribs are all more brittle and rigid, are easy to fracture. They may be associated with underlying the pulmonary or cardiovascular injury. What's the pathophysiology of the rib fracture? Is most often caused by blunt trauma. It always boning effect or with the middle shaft fracture. We should always know most important is the middle shaft fracture. Ribs from 3 to 8 are fractured most often. It's why? Because they are easy to touch because no muscles are covered and are very thin and protected. The other part always just like the floating ribs are always with the skin and muscle, so always not easy to fracture. So other part of the physiology is a respiratory restriction as a result of pain or sprain. Others are intercostal vessel injury. What's the complication of the rib fracture? Is always the rupture of the aorta, severe trauma, or the tracheobronchial tree injury, and other vascular injuries. The most part is the multiple rib fracture is most common thing than the single rib fracture. It always should, when the patient got into the emergency room, we always should assessment the findings. The first is localized pain. The pain that worsens with the movement or the deep breathing and coughing. Always has the point tenderness. Is a specific point, so we touched, so the patient will feel the pain. Most patients can localize the fracture by pointing to the area, just confirmed by our palpitation. Crepitors and audience clutch we always see in the patients. Sprint on respiration. How can we to management of the rib fractures? The first is airway and ventilation. And we always included the treatment is a high concentration oxygen, positive pressure ventilation, encourage coughing and deep breathing. Others we use pharmacology agents just like analgesics. Others we always use non-pharmacological, just non-circumferential spirit, just like to cover the patient with some clothing. This is the most severe of the rib fracture. We always call it free chest. How is it occurred? It always most by vehicular crash, fall from the heights, industrial accident, and assaults, and or the birth trauma. What's the morbidity and mortality? It always mortality rate is from the 20% to 40%, and others always causes just like the 3 or more associated injuries, shock, or the hand injuries. What's the name of the free chest? It's most important for us because he has a severe results. 2 or more adjacent ribs fractured in 2 or more places, producing a free floating segment of the chest wall. So now we know not a single or 2. Should we know the 2 or more adjacent ribs and including the 2 or more places. So after this one, so the free chest usually result from the direct impact. So what's the physiology of the free chest? And we should see the 2 pictures. After, in normal peoples, we inspirate, so the lung will expand. After expiration, so the lungs will shrink. But in free chest, this is always on the other side. On the other side, that this is the broken ribs. This is always called free chest. After inspiration, the normal part is expand, but this part is shrink. But on the other side, when we explorations, the normal part is shrink, but the broken part is expand. So this is caused by the bad imbalance of the pressure between the two parts of the lungs or the chest wall. The most important is an assessment of the free chest. So we should know the chest wall contusion, respiratory distress, we always cause ARDS, paradoxical chest wall movement, and pruritic chest pain, crepitus, pain, and sprint of affected signs. Tachypnea, always tachycardia, possible bundle branch block on the ECG, always called EKG. The management of the freight is included the 4 parts. The first is a high concentration of the oxygen. This is give the first aid help management. The second part is positive pressure ventilation may be needed. Reverse the mechanism of the paradoxic chest wall movement and restore the tidal volume. Reduce the pain of the chest wall movement. Assess for the development of a pneumothorax. So after 2 parts, so we should evaluate the need for endotracheal intubation, then stabilize the freight segment. This is always now controversial now. The second we always see is a pulmonary injury. It always leads to the closed or simple pneumothorax. The incidence of the pneumothorax is 10% to 30% in blunt chest trauma, always almost 100% with penetrating chest trauma. The mobility and the mortality of the pneumothorax is extant atelectasis and associated the injuries. What's the pathophysiology of the pneumothorax? It is always caused by the presence of air in the pleural space, and always a common cause of pneumothorax is fractured rib that penetrates the underlying the lung. So the lung is broken, so air enter into the cavity, thoracic cavity. So we always lead to the pneumothorax. From this picture, we always know that if the lung of the bronchus is broken, so the air can from the tunnel into the thoracic cavity. So we always lead to the pneumothorax. So pneumothorax, closed or simple pneumothorax may occur in the absence of the rib fracture from a sudden increase in intrathoracic pressure generated when the chest wall is compressed against a closed glottis, the paper bag effect. The other effectors always small tears self-seal, large ones may progress. Others always the trachea or the bronchus is targeted towards the affected side. Ventilation and perfusion mismatch. This is the assessment of the pneumothorax. Always we can see the symptoms or the general signs of the tachypnea, tachycardia, respiratory distress, absence of decreased breath sounds on the affected side, hyperresonance, decreased chest wall movement, dyspnea, chest pain referred to the shoulder or arm on the affected side. Others are slight prurite chest pain. This is from this picture we know that this is a rib fracture. So the broken rib is entered into the lung. So the gas will always enter into the thoracic cavity, leads to the pneumothorax. How can we to management the closed pneumothorax? Is high concentration oxygen, positive pressure ventilation if necessary. If respiration rate is less than 12 or 28 per minute, and ventilator assistance with a better valve mask may be indicated. And others, we always use the non-pharmacological needle thoracostomy transport considerations always included position of comfort, unless contradicted by the possible spine injury. Others always appropriate mood, appropriate facility. This is the open pneumothorax. Open pneumothorax is usually the result of the penetrating trauma. It is always caused by the gunshot wounds, knife wounds, impaled objects, motor vehicle collision, and falls. The severity of the open thorax is directly proportional to the size of the wound. If the wound is bigger, so the severity the symptoms is severe. So the profound hyperventilation can result. Others always cause death. It's always related to the delayed management. The open pneumothorax always is an open defect in the chest wall. Is always more than 3 centimeters. And if the chest wound opening is greater than 2/3 of the diameter of the trachea, so the air follows the path into the resistance through the chest wall, which inspiration. As the air accumulates in the pleural cavity space, so the lungs will be on the injury side will collapse, and begin to shift towards the uninjured side. So the mediastinum will shift into the uninjured side. And this is the other pathophysiological of the open pneumothorax is very little air enter into the tracheobronchial tree to be exchanged with the intrapulmonary air on the affected side, which results in decreased alveolar ventilation and decreased. The normal side always adverse effect because expired air may enter the lung on the collapsed side, only to be repressed into the functional lung with the next ventilation. We always result severe ventilation dysfunction, hypoxemia, and death, unless rapidly recognized or corrected. Other injuries always open to pneumothorax is to and from air motion out of the defect. Others, the defect in the chest wall. A penetrated injury to the chest does not seal itself. A sucking sound on inhalation, tachycardia, tachypnea, respiratory distress, subcutaneous emphysema, decreased breath sounds on the affected side. The management of the open pneumothorax is very easy but important. First is a high concentration oxygen. It's the same to other pneumothorax. Positive pressure ventilation if necessary. Assistant ventilation with a bag valve device and intubation as necessary. Just like this one. This is wood. This is a collapsed lung. So we should prevent the air entry. So we cover it with clothes or other materials to do not let the air enter to flow the air into the cavity, thoracic cavity. Others, the severe of the pneumothorax is tension pneumothorax. how can we definition the tension pneumothorax? It is common associated with injuries, just like penetrating injuries to the chest and frontal trauma and others. It always profound high ventilation can result. If we delayed management, it will cause the death of the patients. So if the patient got the tension pneumothorax, so immediately life threat, chest injury, or other management we should prefer. The pathophysiology of the tension pneumothorax is that the following occurs when the air enters the pleural space from the lung injury or through the chest wall without means exit. We always only enters, not exist. So the pressure in the thoracic cavity is increased. So it will infect the patient's the blood system, high hemodynamic system, and other respiratory systems. So the patient will got shock. Increased pleural repression will got the median stand shift. Median stand shift will result in compression of the uninjured signs, hunking of the superior and inferior vena cava, and decreasing the venous return to the heart, and subsequently decrease the hearted input. So always cause the patient's shock, and severe will always lead to the death of the patients. This is assessment of the tension pneumothorax. It included the extreme anxiety, cyanosis, and increasing dyspnea. This is the most important we always see in the patients with the tension pneumothorax. Others we always with difficult ventilation, trachea deviation, hypertension, bulging of the intercostal muscles, subcutaneous emphysema, jugular venar distension, and equal expansion of the chest, and hyperresonance of percussion. This is the physical findings of tension pneumothorax. Always know that the air only enters into the thoracic cavity, but do not exit from the thoracic cavity. So it causes tension pneumothorax. So the patient will always cause the hyperresonant percussion note, will always the breath sounds absent. Others will always cause the mediastinal shift, was the trachea displacement towards the uninjured side. Others will always cause possible subcutaneous emphysema, distension, neck veins, and others increase cyanosis. Always the patient so has a tachycardia, tachypnea, hypertension, blood pressure, so always demonstrate shock. The patient has got skin cold and clammy. So how to management the tension pneumothorax? Always the most important is with the needle thoracostomy. Emergency care is directed at the reducing the pressure in the pleural space. So airway and ventilation, high concentration oxygen, and positive pressure ventilation if necessary. Always circulation. If we relieve the tension pneumothorax, so we always improve the cardiac output. Others always cause non-pharmacological, occlusion, open wound, needle thoracostomy, tubal thoracostomy in hospital management. So most important of the management, just let we use any methods to let the air to flow out of the thoracic cavity, to let decrease the pressure of the thoracic cavity. The tension pneumothorax is associated with the penetrating trauma, so may occur when open pneumothorax has sealed with an inclusive dressing. Pressure may be relieved by momentarily removing the dressing. Tension pneumothorax associated with the close trauma. If the patient demonstrates significant dyspnea and distinct signs and symptoms of the tension pneumothorax. Thank you.